Hello everyone, this is Dr. Charishma. The topic is about zirconia crowns in pediatric dentistry. Is the early childhood caries commonly affects the primary anterior teeth in the young age group children who requires aesthetic management. There are many aesthetic options that have been available over the years, each having its own advantages, limitations, and associated technical issues. Prefabricated zirconia crown is an eventually strong ceramic crown and provides more aesthetic and biocompatible full coverage for primary incisors and molars. Pediatric zirconia crowns were first introduced by Pedo and they became commercially popular in 2008. Later, preformed zirconia crowns were introduced by companies like New Smile, Kinder Crowns, Cheng Crowns, Signature Crowns, Kitsy Crowns, and many more. They are anatomically contoured, metal-free, completely bioinert, and resistant to the decay. The most common oxide of zirconium is zirconium dioxide, which is commercially known as zirconia. This is a crystalline, clear, white-colored solid that has an especially high fracture toughness and chemical resistance, the cubic form. Coming to the indications of zirconia crowns: multi-surface caries, caries involving incisal edges, fractured teeth with proximal surface after pulp therapy, discolored anterior teeth, nursing bottle caries. Contraindications of zirconia crowns are when there is crowding of the teeth, gingival inflammation, or when there is bruxism. Now let's see about some commercially available zirconia crowns. The first is New Smile zirconia. It is made up of high-grade monolith zirconia ceramic. It has increased durability with strength more than enamel. The translucency of zirconia ceramic, it provides excellent aesthetics and prevents the problem of dark tooth showing through pulpally treated teeth. It is also provided with a New Smile try-in crown to check fitting prior to the final cementation. This feature not only saves the clinician's chairs at time but also eliminates extra steps and disinfection of the crown. New Smile zirconia crowns, they have improved marginal adaptation to the tooth and are smaller at the cervical crevice than the other brands. The next is Kinder Crown Zirconia. It is based on a nanotechnology, produces most consistent high quality zirconia. It has polished surface to reduce opposite enamel wear. It has internal retention system which locks the restoration after cementation. These retention bands also provide with additional surface area for bonding. Fine feathered margin of zirconia Kinder crowns makes the emergence profile for the crown as natural as possible. It is available in two sizes, mid-size and regular size. Mid-sizes are designed for first and second primary molars to alleviate seating issues in situations when you have placing crowns back to back or when your patients have experienced major space loss. The mid-sized crowns hold their buccolingual width and at the same time as the mesial distal width has been reduced to allow for easier placement and positioning. The next is pedo crowns. It comes with the patented retention technology, ZIR Lock ULTR. That is, the retention grooves which extend all the way to the crown margins, preventing cement washout. It also prevents entry of harmful bacteria and moreover, it provides 2 times more surface area for bonding. Additional retention is provided through blasting with aluminum oxide. The next is kits e-crown. These crowns are available in two kits, anterior kit and posterior crown kit. The posterior crowns have inner flat occlusal table with uniform axial walls. There are micromechanical boxes for retention. The wall thickness is 0.3 mm and margins is 0.2 mm. The sizes for anterior crowns ranges from 0 to 5 and in posterior there are 5 regular sizes and 3 narrow sizes. The narrow sizes are mid sizes with broader buccolingual dimensions for proximal lesions and spaceless cases. The labeling of the crowns is permanently embossed inside the crown. The next is signature crowns. It has 0.2 mm feather edge margin and 0.5 mm overall thickness. Posterior crowns have flat distal proximal wall of primary first molar and mesial flat proximal wall of primary second molar with no narrow crowns. In anterior, both universal contoured right and left side options are available. There are 1 to 6 posterior and 1 to 4 anterior sizes with no space loss crowns as such as Kid C crown. Coming to the clinical procedure, uh, first step is setting up of all the armamentarium. Now you can see what all the instruments have been organized here. All the diagnostic instruments, burrs, aerator which is required, then floss, gauze, and also the resin modified glass ionomer luting cement for luting the GIC. All these instruments need to be arranged before starting up with the case. The burrs which are needed for the preparation of zirconia crowns are flame-shaped or football-shaped diamond burr, then short needle diamond burr, and flat and tapered diamond burr. Coming to the occlusal reduction, the first step is occlusal reduction, where using the marginal ridge of the adjacent tooth as a reference point, we have to reduce the buccal and lingual cusps to the depth of the central groove, and maintaining the cuspal outline should be there. 1.5 to 2 mm of occlusal reduction is usually performed. An adequate occlusal reduction is extremely important for the proper fit of the zirconia crowns. The next step is proximal reduction. So in proximal reduction, short thin needle shaped burr is used, and it is moved from the buccal side to lingual side. Okay, from lingual to buccal, it is passed. The needle burr is passed. So in both the mesial and the distal proximal areas. And the next step is subgingival preparation. Here, define the preparation around 1 to 2 mm subgingivally. It should be prepared using a long thin tapered burr. Often the it should end with a feathered margin. So there is some remaining band of the tooth structure below the tissue, which helps for achieving the passive fit. How now let's see how the completely prepared tooth looks like. Here you can see the reduced occlusal height, but the occlusal anatomy is almost similar. And then buccally and lingually also it is reduced. 1 to 2 mm of subgingival preparation is also seen, and you can see the proximal walls, near parallel proximal walks with proximal reduction, right? You can say, you can compare it with the adjacent tooth to clearly know how the tooth preparation has been done. Okay, it's clearly seen. Now the next step is the fit try test. We have to test the fit with a try and crown. The most important thing we have to remember here for placing zirconia is that the passive fit should be passive fit should be is required, because zirconia crown is a solid ceramic crown and it doesn't flex. If the crown won't go into the place without the resistance, there is need to reduce more tooth structure. But we should not try to fit the same crown there. And the approximately sized crown will sit passively and subgingivally 1 to 2 mm, and we should not, and that should not alter the gingival tissue. So now let's see how the fit goes after trying with the pink crown. Then you can check with the correct size zirconia crown. Now the crown should sit passively. For the cementation, the tooth and the crown or everything should be clean with all the blood residues. Hemostasis should be achieved, and then resin modified glass enamel cement is used. It is complete. The crown two-thirds, one-third of the crown, two-thirds of the crown should be filled with the cement, and then it should be placed passively. We should ask the patient to bite gently after that, and we should check for the occlusion. So coming to the advantages. High strength and toughness. It can withstand wear and tear. Translucent sufficient to be comparable to the natural teeth. Less tooth removal. Modifiable size, shape, and color. Biocompatible. Good patient acceptance. Coming to the disadvantages of zirconia crowns, they cannot be crimped like stainless steel crowns. Due to the inflammation, gingival bleeding may hinder the cement, which is said to bond the zirconia crown to the tooth. And these are expensive crowns compared to the other crowns. Some of the few specific features of zirconia crowns are they can be sterilized by the autoclave and also other methods like sandblasting, sodium hypochlorite, or cleaning solutions such as Zirclean or Ivoclean, etc. Zirconia crowns they fulfill excellent aesthetics, full inclusion of the treated or caries tooth, no parts of the crown that may debond, and a less delicate procedure for cementation, contrasted with the resin strip crowns for the anterior tooth. Resin-based luting cements are used for the cementation of zirconia crowns. Salivary contamination of the crown during trying of the cementation may weaken the bond of the resin cement. So failure of the zirconia crown is also noted sometimes when the zirconia crowns are improperly polished from the manufacturer and only glazed can be destructive to the opposite tooth structure. So to conclude, prefabricated zirconia crowns are retentive, aesthetically acceptable by both parents and children. It is expensive compared to the other crowns in the pediatric dentistry. Thank you.